Sorry, at the beginning, I really should have mentioned that, this conference really wouldn't be possible if it really wasn't the support of Dr. Sharma and Dr. Kini, who have really, again, teaching to affect everybody. So really wanted to thank them for their generous support. I'm now really honored to introduce to you Dr. Annapoorna Kini, who is really the endowed professor of the Michael Zena and Michael Weiner Professor of Medicine. And she is one of the very few, I think only, very few directors, female directors of the cardiac, top, the number one cardiac, she's director of our cardiac cath lab, but there's very few really in the country. She is also the program director of the Interventional Cardiology Fellowship and the director of the Structural Heart Interventional Program. She's an international leader in the field of PCI and heart valve therapy. She is internationally acclaimed for expertise in performing complex and high-risk interventional procedures, especially in chronic total occlusions, calcific, and bifurcation lesions. She's been among the first interventionalists. She really is the leader with Dr. Sharma and TAVR and mitral clip. She's a high-volume operator, like we said before, has over every year always gets recognized by the Department of Health with her 2-star for safety. She received the 2011 Dean's Award for Excellence in Clinical Medicine at the Mount Sinai Medical Center. Again, Physician of the Year, which nurses don't give out lightly, in 2014. Excellence in Medicine Award by the National Association of Physicians of India in July of 2016. She also received the prestigious Ellis Medal of Honor, Ellis Island, in May of 2017, which is the highest award given to any immigrant civilian. She is the recipient of the American Heart Association Heart of Gold Award in June of 2018 and received the Jacobi Medallion Award in 2019 for breakthroughs in clinical care. And like Dr. Sharma had mentioned in March, she was really the leader, very recognized as the number one clinical trial, the Yellow Trial at the American College of Cardiology, which I can tell you received so much press. So we're really thrilled to now introduce. Now, Dr. Kini is going to be speaking to us. It would be nice if I introduced the title. She's going to be talking to us about the practical application of the new BifurcAID, STEMIcathAID, and the AIDS, other apps. So please join me in welcoming Dr. Kini. Thank you.
Thank you, Beth. If everybody can hear me and see me. Okay. So as per the introduction, I think Beth already mentioned during her initial introductory speech about the apps that we have been doing in the cath lab. And I think Dr. Sharma also mentioned the goal from Mount Sinai Cath Lab has been education, and education by doing live cases. And what we decided a few years back that the future of teaching would be by having apps rather than reading textbooks. That's how we started. So this is the library of the educational apps that we have created, which is available on cardiologyapps.com. And if you see, we are over 75,000 downloads, and these apps are free to be downloaded, available both for iPhone as well as for Android phone. Most of them are all interventional cardiologists, as for technicians, as well as nurses. The new one that we released is called as the IVUS, which was a lot of imaging that was done yesterday to understand what it is. And a lot of these apps will be covered by Andrew later on. For the cath lab nurses and technician, the important app could be the device aid, where every cath lab device has been discussed. So I'm going to be talking on 3 important ones, which is BifurcAID, how to take care of bifurcation lesion, management of STEMI, and management of shock patients. So what is bifurcation? As you see, it's a lesion that you see in coronary artery. There is a main coronary artery and a side branch. If a lesion occurs just at that level, it is called bifurcation lesion. 15 to 20% of the PCIs that we do are a bifurcation intervention. Why, when every live case covers bifurcation? Because it's technically challenging. There are multiple permutation combinations, and you saw during the live case yesterday, Everyone wanted one particular technique. We showed a different technique. So amongst the interventional, there is no consensus how a particular bifurcation lesion has to be done. So multiple permutation combinations are possible. So we created this kind of app saying that if you see this, how to proceed further. And there's no single source available to understand how to do this procedure. So I'm just going to go over mostly the left main because this is the most hardest bifurcation. Left main stenosis, again, about 5 to 7%, and 80% of the stenosis involves the left main bifurcation. So it's the largest coronary artery. If you see here, the size is about 4.6 plus or minus 1, length about 10, and of course, angle is there. And most of the lesion goes into the LAD, 90%, some of them into the circ, as you see here. So what are the various trials that are out there? Most of the trials have discussed one, and I think you heard about this technique a lot of this discussion yesterday on DK crush. Is a double crush kissing stent, and that is what DK crush, and we like to do what's called as a mini crush. There's never been a direct comparison between DK crush and mini crush. Majority of the comparison, DK crush Coulott's technique, DK crush and tap, DK crush provisional, all these things have been discussed. So the last published trial was a DK crush 5, where they compared simple versus complex lesion. Complex lesion means they had to have any of these criteria. Most of the important criteria is that you have disease before, after in both the branches. So this is the Medina classification, lesion length, as well as the angle. All of them were done. And essentially what the trial showed, and what we also teach, that if you have a complex lesion and the vessel size is large, you got to do 2-stent technique. Try not to do provisional stent technique. Why? If you do provisional stent technique, the subsequent outcome is poor, because why? You will do a single stent, and now the side branch has a problem. Now you try to take care of the side branch, you have to recross. There is a problem, the side branch may close. There would be MI. It's difficult to get the stent into the side branch. So we've seen that in this trial. So that is why if you think it is a challenging bifurcation lesion, try to do 2-stent technique. And we tried to make this point yesterday during the live case also. Now, the question always comes, when do we decide? Everybody likes to do provisional stent, essentially. Means you put a stent across in the main branch, the side branch you balloon and leave it. That's not a bad idea at all. But there are certain criteria we need to follow. In left main, like I said, if it is 111 and diameter stenosis of the side branch greater than 70%, length greater than 10 millimeters, when you see this, very important that you have to do 2-stent technique. There are certain minor criteria also, but very important you remember this criteria. So when you see this, go with 2-stent technique when it is major criteria or the complex lesion. Why it's important to know which way a technique to be done? If you see here, studies have shown that if there is an experienced operator means that person has been doing more than 25 PCIs of the left main per year. So you just think that way, that you have good experience, your outcomes are better. We know that practice makes you perfect. So that is why it's important that you learn one technique, master the technique, and perfect the technique so that you do a good intervention on every patient. Yesterday, we also showed a lot of imaging. So more and more data is coming that if you're doing intervention, especially of the left main, you got to do some kind of imaging, that's IVUS, especially at the end, to make sure that you have a good final outcome. So if you see here, this is the guidelines, so much so, guidelines are 2A, that every case of especially left main or any complex intervention, it's better you do either IVUS or OCT guided intervention. Post is very important to understand the stent has fully expanded. There is a good apposition. And if you see here, most of the trials, about 30-40% have imaging. I think this is always up for discussion. And also, I think what the numbers we are saying is that if you are doing intervention, try to do at least 30% intervention. So of the various techniques that are out there, DK crush has made it to the guideline, and it is a class 2B. So that is why a lot of discussion yesterday was on DK crush and never think mini crush. Now bifurcation lesion, how to understand which bifurcation lesion and how to do them. So like I think Dr. Sharma also mentioned that we have live cases, archived live cases. You can go to our ccclivecases.org and see our old videos. The case that I'm going to show is from January 2022, the live case that we did here. So in 2022, these are the live cases that came out from Mount Sinai. About 20 bifurcation PCIs were done live. Of that, 10 left main of the 48 live cases that we did in 2022 there. So this is one of the example, left main. So if this is how the app will show. When you open the app, Bifurcate 3D, you decide whether you want to look at left main or non-left main. So this is the left main intervention. And then patient is stable, okay? It's not hemodynamically unstable. And you decide which is a technique you want to do, because these are the 3 most common technique people like to do. We did not mention provisional because it's very easy to do a provisional technique. So how would you do a mini crush technique? So you have the main vessel. Main vessel usually is left main to the largest vessel that feeds from the left main, which is LAD. So you wire the main vessel, which is LAD, then you wire the side branch. And then also you see here, you see the animation. Then in the side, you will see how the procedure can be done by the side. So you pre-dilate main, then you pre-dilate the side branch. If you think it is suboptimal result, we can do what is called as atherectomy. Now, if there is calcium, then it's a different story. You would want to do any kind of atherectomy. There are various atherectomy devices, and all of this will be discussed in the upgraded CalciFIC that will be coming in the next few months. So this is the mini crush technique. You see the side branch stent that is sitting there. You always advance the side branch stent first, the main branch stent afterwards. Then you inflate the side branch stent. You remove the balloon, remove the wire, and then if you think it looks good, we are done. And then you will go to the main vessel stenting, which is extending into the left main. So always there's a discrepancy. I told you already the left main size could be 4, 4.5. LAD usually is 3, 3.5. So how are you going to take care of that discrepancy of the diameter? So you see here, the stent of the left main is not fully expanded. So what you have to do is what is called as a term called POT, that is proximal optimization technique. You put a short balloon in the left main, dilate it so that the left main part is nicely expanded. Yeah. Good. You see that? Beautiful expansion. And then you look at everything, looks perfect, and we are done. You do a final kiss balloon here. This is the final angiogram. So this is how this app will help you, guide you step by step to do this technique. So that was left main. There are various combinations, permutations. What could happen if something goes wrong? How would you handle how to cross side branch? What are the wires? So if you see that, there's classification, basics, wire selection, and techniques if you get into any issues. So everything is covered here. And also there's a website. So what is the future that we plan to do? That bifurcation 23 and beyond is artificial intelligence is the new thing that what we have so many cases that we have done. So the future goal is once you've done a diagnostic angiogram, there will be an automatic lesion detection. Once that lesion detection is done, now the AI will tell us, okay, this is what is this lesion looks like. And in this case, there are 2 ways you can do it. Either you want to do mini crush or you want to do DK crush, or the third is provisional. You click it, then for that particular patient, This is the way the technique has to be done, and step by step, it will guide you how to do the procedure. This is the future, and this is what we are working on. Now going to the next one, which is a Stemi app, essentially to take care of the patients who are having heart attack, that how this platform can help multiple teams to be on the same, understand how to take care of the patients. Why did we create this? So if you see here, what has happened? As soon as a STEMI arrives, either into the ER or to another hospital, they have to go to the cath lab. So if you see here, things have plateaued. So in 2016, FMC, the first medical contact to PCI time just plateaued. It stayed around 80 minutes. Same thing, door in, door out. Door in, door out should be less than 40 minutes, but we have never reached that time, and everything has plateaued and nothing is changing. Same thing with the semi-transfers. So this was presented during the AHA last year. So if you see here, 120 minutes. We've never met the time of 120 minutes except one quarter, and that too only 25% of the cases met less than 120 minutes door to balloon time in a transfer case in America. So if you see here, the number of cases that they actually looked into, over 22,000 patients, and we cannot meet the timing, especially when we are transferring the patients. Door in, door out was okay, but the transfer does not happen. Why is it so difficult? Because multiple people are involved and there is multiple steps. So this, everybody knows about this. Initial EKG, EKG has to go to the physician has to approve, discussion between ED physician or cath doctor, then the team activation, preparing the room, a lot of things are involved. Can we use the current technology and then decrease everything? So how can we improve this outcome even better? So if you see here, what does the app do? Normally, you take a picture and then send it directly to the interventional cardiologist. So all the middle people are out. Then that ED physician will be talking to the interventional cardiologist directly. And once the activation happens, the whole cath team is on the chat, and they can talk to each other about, means on the chat, talk to each other. This is a HIPAA compliant chat, so we are all safe. And the other thing is also that there is a EMS you can see on that. So this is one of the case that we did, that was a transfer that had a LAD lesion. So if you see here, door in, there's a time 0. EKG was done, which is within 6 minutes. Then the semi-activation happened. Patient came out within 37 minutes, transferred here, came to our hospital at 64 minutes, and device time was 78 minutes. So this is one of the cases that we have done. There are several cases like this. So look at the timing. This timing is better than the door in, door out, if the patient would have come to our own ED here. So again, having the app, all we have done, if you see here, average time of the USA for the transfer, if you see here, barely about 20% makes less than 120 minutes. We used to be less than 80% of the cases made it to less than 120 minutes. After we started using the app, we have 100%, every case has made less than 120 minutes. So why this can happen is only because of education, as well as this particular platform is a great one to be used. So if you see here, door in, door out in the past for us used to be about 68 minutes or so. Right now, we are 52 minutes, which is, we still want to improve on that. And door to device time, look at that. In the past, we barely used to make it 100, or we are about 91 minutes, which is a great thing. What's the future? The future is that as soon as EKG is done, use AI machine learning to understand what that EKG is, that if this happens in patient's house, that you have the paramedic do an EKG, the EKG is uploaded through the photo to the app or even to EHR, no matter what system we want to use. That will be processed and there will be alert STEMI, and that STEMI alert can go to the nearby hospital. So whoever is a nearby hospital will take this patient. And then what's going to happen is AI recognition of the voice. So when they're taking care of the patients, whether it is in patient's home, in the ambulance, patient in the ED, people are busy taking care of the patient. The patient could go into VFib, could go into a lot of, if it's not stable. As you're talking, that voice activation goes to the cloud, and that gets transmitted to the team who is waiting for the patient. Exactly the pathway for the future is two things. One, patient is non-CAD, may be carrying some kind of a wearable device where the EKG will alert the patient gets STEMI. That is maybe a small percentage of patients. But what is more important could be that everybody could carry this on their phone, that there is an alert system, that somebody collapses in the house. Now, whether it's a STEMI, cardiogenic shock, or whatever it is, they alert the EMS. So EMS is dispatched, and then the alert could even go directly to the interventional cardiologist, the physician, the primary physician, which is PMD notification can happen. Once we know it's a STEMI, you see that team is mobilized, rooms are ready, and if the patient is in cardiogenic shock, equipments are ready. So this is the future goal for us to work on to improve STEMI. Now, the final one that I'm going to talk on, just an extension of the same thing, that if there is patient presenting with cardiogenic shock, what do we do? So what is cardiogenic shock? Patient presents with hypotension, and 52% the etiology is some kind of a heart failure, chronic, 32% is AMI. But if you have acute MI that presents as cardiogenic shock, look at the mortality, 42%. If they have out of hospital cardiac arrest, 52% mortality, very high mortality. So we have to do something, because coronary artery disease as well as STEMI is still the leading cause of death in the world right now. So we need to do something to take care of that. So look at the numbers for cardiogenic shock. 10% of the MI can go into cardiogenic shock, and mortality 40%, 50%, 1 month at 1 year. So they need, how do we prevent this? Immediate recognition. They need to be in the cath lab so that we can do immediate revascularization of that infarct-related artery. So they need to go to the cath lab immediately. That should be our goal. It has made it to the guidelines also. If you have ST segment myocardial infarction and cardiogenic shock, it's class 1 to go to a cath lab primary PCI. If it is a non-ST segment myocardial infarction, still you have to, and cardiogenic shock, emergent PCI of culprit vessel. Why shock is taking such an important role? Because there are devices, though they are not class 1, they're class 2A, 2B, there are devices for LVSs that we can use to help patients who are in shock. And that is why you need a team that is alerted. And if you think the patient is in shock, as the patient gets into the lab, there is the ECMO team ready if the patient needs ECMO, especially if the patient has had out of hospital cardiac arrest. So this is the shock classification from the SCAI. And you see here, it's easy to remember A, B, C, D, E. B, C, D, E are, actually bad. Why? You have to know a couple of numbers, not just the blood pressure, tachycardia, lactate numbers are very important. So this is how you take care of these patients. And what is important about this shock is that it's a dynamic process. You may think, oh, shock, I started a patient on some pressors, blood pressure is coming up. Patient may recover a little bit, but could immediately deteriorate from stage B, C to D, E. So we got to be very alert on that. And what studies have shown that B equal to actually is bad, that becomes C, D, E very quickly. If you, for any reason, have placed any kind of circulatory assist device, there are 3 reasons you'll do that. It's pure cardiac, could be a cardiac pulmonary problem, or could be just a pulmonary problem, which could be a VV ECMO. So you need to understand who should get what. You need to understand when they're recovering or deteriorating so you can escalate. And third, if they're improving, you need to know how to wean them off. So the new app that we created called as MCSAID, again, is an app which is simple. You will know various devices that are used in the cath lab and what are the basic definitions. The way we like to put it, that everything is just a bullet point and very simple. to follow. So you can just use a calculator, which is at the bottom also. Now, calculator gives various hemodynamic references, the formulas that we use, and the numbers, that is the normal reference number, which we need to know in this patient. So an example where we use this app to guide how to take care of the patient. 61-year-old, out of hospital cardiac arrest, recovered from the cardiac arrest, presented with cardiogenic shock, and intubated. So initial number, labs were okay. EKG showed ST elevation. So what is our app tell us how we should proceed? So this is a decision-making, MCS decision-making algorithm. Post-cardiac arrest, and patient was resuscitated. And then what happened? EKG was ST segment elevation, and it was non-refractory, means patient recovered. Stemi on the EKG, so go to the cath lab. Patient came to the cath lab and look what we see. Proximal occlusion of the LAD. So EDP was 25, EF is 25, EDP was 32. So once we do the PCI, so blood pressure was low, EDP is high, we have to support with an Impella. So after we did the cath, Impella guided PCI of the patient was done. Recommendation is immediately do a right heart cath. So you don't waste your time doing right heart cath before the PCI. Finish the PCI. Once the artery is open, do a right heart cath. And what did the right heart cath number shows? These are important, you have to know. Cardiac power output and pulmonary artery pulsatile index. Many of the nurses who are already in the lab, they will know these numbers. If they're ICU nurses, they have to know when they're taking care of these patients in the ICU. So in this patient, CPO is 0.70, borderline, if you see here. Okay, the goal has to be less than greater of 0.8 should be the goal, and PAPI 2 at the goal. So it was just borderline numbers this patient had. We took the patient to the CCU over the day. If you see here, multiple episodes of arrhythmias, then CPO dropped to 0.4, PAPI drops to 0.8. Then what do we do? This, the algorithm continues. The algorithm now says if the patient is, not doing well on just Impella, there has to be some kind of escalation. The escalation could be the percutaneous ECMO. So we escalated to VA ECMO. But before you do that, because of multiple arrhythmias, you just have to make sure that patient did not have acute stent thrombosis. Subsequently, patient did very well. And there's a weaning algorithm which we followed. So all drips were weaned off, and ECMO was removed day 4, Impella removed day 6, and patient discharged home. So the future is, you have STEMI, you have shock. Can we combine both? And same like I mentioned, activation can happen from the EMS, activation can happen from the patient or family to take care of this. So the final take-home message is that an AI-powered cath lab is closer than ever. So combining our experience in complex bifurcation lesion treatment will create an AI algorithm to automatically analyze bifurcation lesion and use our educational work to recommend technical treatment strategies. App technology provides the unmet need in managing STEMI, and the future direction involves integrating shock algorithm, team alert system to further enhance management strategies. Thank you for your attention, and more about these apps available on cardiologyapps.com. Thank you.
So truly amazing of how far we've come even in the last year, right, Dr. Kini? I mean, amazing.
Yes.
And my brain is spinning around because I really think that we need your help in the nursing orientation for any nurse in the cath lab across our health system. We need Dr. Kini to give a class on this because this is really the future. So any questions for Dr. Kini? Okay. Thank you, Dr. Kini.
Thank you.
Thank you. Thank you so much again. Amazing.